Okay, I guess I'm going to go ahead and start. Can everybody hear me? Somebody nod or say, okay, great. All right. So thank you all for attending. And I'm going to go ahead and introduce myself. I'm going to talk to you a little bit about cross-sectional longitudinal assessment of chronic pain after spinal cord injury. I am a research associate professor in the Department of PM&R. I'm also the project director of the South Florida Spinal Cord Injury Model System, which is a sort of joint collaborative grant between our department, Jackson Hospital, Rehab Hospital, and the Miami project as well. I also have an appointment at the Miami VA Medical Center, do a little bit of research there. So I'll go ahead and start. Let's see. My first, there we go. All right, so I'm going to sort of, I am going to talk about some data today. It's sort of a little bit of new data that we have collected. But I just want to start out talking a little bit about pain, because I think sometimes I as a researcher who have been doing this for a while sort of get lost in it sometimes, and it's nice to kind of take a step back. It's also nice for people who don't study pain or don't see it clinically to be able to understand a little bit more about the complexities of it and how we try to define it and how we try to measure it. So the International Association for the Study of Pain has a definition of pain that is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. This seems relatively straightforward, but then when you look at the note that accompanies this, you see that pain is a little bit more complex than it at first seems. So I'm going to just highlight a few things in this note because I do think they're important, and I think it's important for people to think about, both clinicians and researchers who don't study pain, how pain can impact other things and how other things can impact pain. So pain is a sensory and emotional experience. So pain is always subjective, and we hear this all the time as pain researchers. Well, how can you measure it? It's a subjective. It's true, it's subjective. We are humans, and we perceive things in our environment, and we have to report them. That does not mean that it cannot be measured. So pain is subjective, and we learn the application of the word through experiences. So it's important to note that previous experience with pain impacts not only how you report pain, but also your experience, your actual experiences of the pain. Early experiences in life can set up your perception of pain, can impact your perception of pain later in life. It's also important to note that even though we sort of tie pain to tissue damage, like there's an instigating event, the definition of pain is not necessarily just based on the sensory perception, but is also an emotional experience. It's an unpleasant emotional experience. Not every unpleasant sensation is necessarily painful, but pain is coupled with the sensory experience and an emotional experience. When people report pain, we have to believe them. If a person regards their experience as pain, and if they report it in the same ways as pain caused by tissue damage, it should be accepted as pain. So even if we can't figure out with our current tools, diagnostic tools or whatever, if we can't find where the tissue damage is, it still is accepted as pain. That is part of the definition of pain. The person reports it as pain, it's pain. The definition avoids tying pain to the stimulus. So activity induced in the nociceptor and in the nociceptive pathways by a noxious stimulus is not pain. Just measuring the activity in the pathway is not pain. It's not until that experience reaches our cognitive perception that it is pain. So pain can be measured in humans because we can report it appropriately. Typically, in animal studies, people do not report outcomes as pain, but report them perhaps as nociceptive behaviors within the animal or pain-related behaviors or pain-related responses in the animal. So pain is sort of a uniquely human experience in that way. We have things that are, we can measure many things in animals, in non-human animals that are associated with pain, but it is really not part of the definition of pain. Okay, I think that's all I wanted to say about that. Now, we need to measure this thing that is complicated. So this is just a definition of pain that I pulled from the internet. That seems pretty appropriate. Pain measurement, a standard unit of measurement, is a quantifiable language that helps everyone understand the association of the object. Standard unit of measurement provides a reference point by which objects can be described. So we need a standard unit of measurement that is in quantifiable language, so we can all understand this experience, this complicated experience, but we have to be able to measure it. Now, typically, this is what people think of when they think of measuring pain. You go to the urgent care, or you go to your checkup or whatever, the clinic, and you complain of pain, and the physician may ask you to rate, or the nurse or whatever may ask you to rate the intensity of your pain. So usually people use the numerical rating scale. So this is from 0 to 10. Usually it's verbally reported. They'll ask you, on a scale from 0 to 10, and you can report it verbally, or you can also, if it's on a survey, you would circle the number that's associated with the intensity of your pain. We also use the visual analog scale, which is a more continuous measure of pain. And this is just a 10 centimeter line where people can put a mark on the line to indicate the severity of their pain, sort of like a thermometer. People use words. You can use words to measure the intensity of the pain. And even in younger people, or people who may not be able to express themselves with numbers or words, faces with different expressions on them have been validated as appropriate measures of pain intensity as well. And you can see from the faces the emotional experience of pain that is also a part of the pain definition, not just the sensory experience. So this is one way that we measure it, pain intensity. But then when we look at this definition of pain and all of these complicated things that go along with it, it doesn't seem that one number can really represent it. And in fact, when you talk to people who have chronic pain or who've had chronic pain for a long time, it's almost insulting to them when you ask them to describe their pain or rate their pain on this, tell me about your pain, 0 to 10. And that's all that you have. So when we think about pain outcomes, we need to think about more than just pain intensity. Pain intensity, these types of measures are important for giving us a common language, and using these simple sort of measurement tools are a good way to give us a common language. And in fact, pain intensity is the primary outcome variable that most analgesic trials are required to show effectiveness for. So it is important, but we also have to remember that pain is an unpleasant emotional experience as well. So we want to measure other aspects of pain, and these are appropriate outcomes that we're interested in. And additionally, particularly when we're thinking about humans, real people who go to the clinic and talk about their chronic pain problem, if we want to help them, particularly in physical medicine and rehabilitation, we're particularly interested in function. So it's not just how bad the pain is, the pain intensity, but it's how it impacts their life. And those are some outcomes that really should be more focused on in terms of what we're looking for when we're trying to understand pain, and and that in turn will help us better treat pain. So that is how we can measure it. So let's talk about pain after spinal cord injury for just a brief introductory. This is an old picture that Eva probably recognizes. This is from one of our earlier studies when I worked in Eva's lab as a postdoc. And this is just, I keep this slide with me because it's a good representation. So drawing from one of our participants with spinal cord injury who participated in a neuropathic pain study, and we did interviews with them to describe their pain. So not only do we have this, complicated definition of pain and all these outcomes that we're interested in, but in spinal cord injury, we have more than one kind of pain. People aren't, sitting around with just one pain and you ask them, what's your overall pain, 0 to 10? Well, they say, what are you talking about, my leg pain? Or are you talking about my back pain? So it's important to recognize that people with spinal cord injury and other people as well, that particularly in this patient population, the majority of people with spinal cord injury report more than one pain problem. And they can talk about them as separate pains. They can rate them separately. So this again is some old data, but it shows that when you ask people to tell us about your pain and which pains they have, they're going to tell you about more than one pain. So the majority of people have at least 2 pains. So it's even more complicated than this. And in fact, the recommendations from the experts in spinal cord injury and pain suggest that we do differentiated assessments. So this is the International Spinal Cord Injury Pain Basic Data Set. There's also an extended data set that we use. This is part of the International Spinal Cord data sets that are put together by this international consortium of people, experts in the field. And it's not just for pain, there are international data sets for autonomic dysreflexia and many other conditions that are associated with spinal cord injury. But this is the the basic data set for pain, and this is what is used, again, this is what has been proposed to be used across clinical studies, across in the clinic and also for research studies, to provide a basic set of data across studies that we may be able to pool this data together and show relationships between different studies. And so what I want to point out here is that, one of the first questions that they ask is, how many different types of pains do you have? This is not just something that, I'm coming up with or we've thought about for a long time, but the experts agree that we can ask about more than one kind of pain, and then we can ask them to tell us about their pains. And in fact, in the basic data set, it's recommended to have the person describe up to 3 of their worst pain problems. And so they can tell you where they're located. We can look at the type of pain it is, the intensity of the pain, and then there are also a few other questions that we ask. So we have this complicated thing that we're trying to measure in many different ways, and we also have more than one kind of pain that we want to measure. So how do we do this, and why do we do this in people with spinal cord injury, chronic pain assessment? So one thing that we really want to know is what type of chronic pain they have. So we're differentiating the pain assessment so that we can see what kind of pain it is. Like in the example that I showed before, there are different descriptors that people use. Sometimes it's sharp, sometimes it's burning, maybe it's aching. So different types of pain may have different qualities that people describe. There may be different temporal qualities. This particular pain is with me all day, all night, it's always there. My other pain is only present during certain parts of the day. And then other clues to what type of pain it is are the exacerbating and the alleviating factors. Is there anything that makes your pain better? Is there anything that makes your pain worse? And this can also help us differentiate pains. And the importance of differentiating these pains and telling what type of pain or classifying the pain is that we may be able to figure out what's causing the pain. This is in general, but also in spinal cord injury. We may be able to figure out what's causing the pain, what the underlying mechanisms are for that pain. And then, of course, the main goal would be to treat it, to try to alleviate that pain. And the more we know about what kind of pain it is and the mechanisms that underlie that pain, theoretically, the easier it is to treat. just a note really quickly, because I didn't say this at the beginning. If you have questions, I'm not going to check the chat until the end, so I apologize for that, but it's just going to be a little too distracting. So if you have questions, you can put them in the chat and I will try to address anything in the end. Okay, so what types of pain are we talking about? Well, this is the International SCI pain classification table. The two primary types of pain that we talk about, not just in SCI, but in chronic pain in general, are nociceptive types of pain and neuropathic types of pain. Nociceptive pain is basically normal pain that everyone experiences. So pain that arises from actual or threatened damage to non-neural tissue and is due to activation of nociceptors. So when you stub your toe, that is pain. It's not chronic pain unless it doesn't go away forever, but that is a typical nociceptive type of pain. Or when you work out and you haven't worked out for a long time and you get a sore muscle, that can be a type of nociceptive pain that should go away after a few days. The note for nociceptive pain is that this term is designed to contrast with neuropathic pain, which I'll talk about in just a second. This term is used to describe pain occurring with a normally functioning somatosensory nervous system, to contrast with the abnormal function seen in neuropathic pain. So we have nociceptive pain, which is in a normally functioning somatosensory system, and then we have neuropathic pain, which has a much longer note that goes, off the page. The note's not that important, or I'm not going to discuss it, I should say. Neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. So this is the kind of pain that people with spinal cord injury have, both nociceptive pain and neuropathic pain. It's very common to have neuropathic pain after spinal cord injury. And neuropathic pain in general, sometimes it is difficult to diagnose because although the person may have the descriptors that are typically associated with neuropathic pain, like a burning or tingling kind of pain, they may not, the physician or the clinician may not be able to find where the lesion of the somatosensory nervous system is with the diagnostic tests available. Fortunately, neuropathic pain, this is pretty easy. So this aspect of diagnosing neuropathic pain is pretty easy in spinal cord injury because we know that there has been an injury to the somatosensory nervous system. So, okay, so these are the things that I'm interested in studying: nociceptive pains and neuropathic pains after spinal cord injury. And I'm going to talk about one specific cross-sectional study that we have completed data collection, and I'm doing sort of the initial data analyses, and I'm going to present those today. So cross-sectional studies can help us determine the frequency and the characteristics of pain after spinal cord injury, and can also provide us with possible associations between the pain, the clinical pain, and other factors. And these associations may help us figure out what is generating the pain, what makes the pain worse, how we might be able to treat the pain. So the prevalence of chronic pain in general after spinal cord injury, we have a lot of people in the US, about 300 people in the US living with spinal cord injury. Presently, that's the estimate. And in those people, a lot of them have chronic pain. These are just some of a little bit of older studies showing chronic pain in general in people who have spinal cord injury. The point of all these is that we know that chronic pain after spinal cord injury is common. It's often severe. It's persistent. So it doesn't go away after the first 2 years of spinal cord injury, and when your nerves settle down or whatever you want to call it. It's there. It's hard to treat, particularly neuropathic pain is very difficult to treat in this patient population. And chronic pain greatly impacts life. So people with spinal cord injury are already, their spinal cord injury has affected many aspects of their life. But when you add on pain, that can even further impact their life. And in fact, it can impact their ability to participate in rehabilitation activities, which then can affect, it's like a snowball effect. So if they're not able, because of their pain, to participate in rehabilitation, their outcomes may not be as good. So in general, this is what, this is the prevalence and impact of chronic pain after spinal cord injury. But one of the things that we wanted to know was how these two different types of pain that we talked about, neuropathic pains that are particularly tied to the spinal cord injury itself, and nociceptive pains, how they may differentially impact a person's life who has a spinal cord injury. So this study was done in chronic traumatic spinal cord injured participants who were from 1 year post-injury to 45 years post-injury, and they were enrolled in our National Spinal Cord Injury Model Systems database. We did a phone interview survey. It took about, if the person we took, so it wasn't just in people who had pain, it was all of our sample of people with spinal cord injury, regardless of whether or not they had pain. But the first question, of course, was, if they had pain during the past 7 days. Now, if they answered that question negatively, then their survey was very short. But the longer version of the survey, if they do have pain, took about 20 to 40 minutes, depending on how many different types of pain the person had. And this is a collaborative study that we've been undertaking with some of the other SCI model system sites. So we're the lead for this study. Then Mount Sinai in New York, University of Alabama, Birmingham, TIER in Texas, Craig Hospital in Rancho Los Amigos in California, all contributed data as well. What we did, so part of the pain interview, we used the International Pain Basic Data Set. We also used parts of the International SCI Pain Extended Data Set, though I'm not going to talk about the data from that today. Again, you've seen this before. So we asked them where their pain was located, how bad it was, and then we also asked them impact. I don't know, this is a little bit blurry, but I'm going to present it in more detail a little bit later. We asked them how much their pain interfered with day-to-day activities, overall mood, and then how much their pain interfered with their ability to get a good night's sleep. So, so we asked them to differentiate their pain. So for each of their first worst pain, their second worst pain, and their third worst pain, we asked them to tell us these details about their pain and to tell us the impact of that particular pain on these different aspects. Now, one thing that is here is that we have to figure out what kind of pain it is. Typically, this requires, or it does require, an actual diagnosis requires a clinician seeing the person and evaluating many different aspects of their pain and deciding whether or not it's a neuropathic or nociceptive pain. And this, again, will help the physician determine how to treat it. So we did not have the ability to do that because we wanted this to be a large study, cross-sectional study, over the phone, so people didn't have to come in. So what we used for this was a relatively recently developed tool that has been validated in people with spinal cord injury. And it's based on some other neuropathic pain questionnaires and other patient groups, or general neuropathic pain questionnaires. And this one was whittled down to 4 questions, particularly for people in spinal cord injury. And what this allowed us to do was to quickly sort of screen. I won't say we diagnosed anyone, but we screened. We were able to divide up the pains as the person described them into whether or not they were probably neuropathic in nature or they were non-neuropathic. So on this particular, for this particular tool, if you score a 2 or more out of 4, 2, 3, or 4, then it is likely that you have a neuropathic type of spinal cord injury pain, or a neuropathic type of pain. And then if you score less than a 2, so a 0 or a 1, then it's probably a non-neuropathic type of pain. And so this was an important tool for us because we were able to do the study on a large scale over the phone with people and still be able to differentiate their pains into the 2 different pain types so that we could assess the impact of different pain types on their life. So basically have said these things already, or at least the first one. We wanted to differentially assess the impact of chronic neuropathic pain and chronic non-neuropathic pain on activities, mood, and sleep in people with spinal cord injury. And we also were looking at associations between different characteristics, demographic injury characteristics across this patient population, participant sample, and the presence of chronic neuropathic pain and the presence of non-neuropathic pain. Some studies have been done looking at the associations between these factors and chronic pain in general after spinal cord injury, but not specifically for the two different types of pain. So we had 391 participants complete the questionnaires or the phone survey. And this is just a little bit of the demographics of the participants that we enrolled. They're pretty representative of the SCI population in general in the US. So we had about 20%, 19% females. We had a good distribution of different races, majority white, but a large proportion of Black or African American. And then we had about a quarter of the population that was, or the sample that was Hispanic. We had a good distribution of age at injury. It's a little bit more weighted, the lower age. So this is the age of the person when they were injured, not when they were interviewed. And then this is the distribution of the participants across years post-injury. So one of the things here is that with spinal cord injury model systems, we enroll participants when they are in inpatient rehab, and then we follow them for years and years until their death or until we can't find them anymore. We follow them at year 1. So we already have standing interviews, expected interviews for the spinal cord injury model systems at 1 year post-injury, 5 years, 10 years, 15, etc. So we took advantage of the fact that we were going to be contacting participants at these time points, and we added on the additional pain questions or the pain interview at these time points. And we specifically sampled, we set goals for recruitment at different centers based on the number of years they had been participating in the spinal cord injury model systems database, so that we could get relatively even distribution of years post-injury. So people who had more chronic injuries, and then we had an oversampling of people who were 1 year after their injury. So those are the people that we interviewed. Again, we found what we found before is that overall, having pain, about 80% of people reported having at least one pain problem. And the majority of people reported having 2 or more pain problems. And when we look at the frequency of the different pain types, this is overall pain. How many different pain problems do you have? And then this is looking at how many people have different pain types. Again, there were 20 people that didn't have any pains, but over 50% had reported at least one neuropathic pain, and almost 50% reported at least one non-neuropathic pain. So this chart figure is just showing the distribution across the different times since injury, years since injury. No pain group is about 20%. People who had at least one neuropathic pain is a little bit over 50%, and people who had at least one non-neuropathic pain is about 50%. And one of the things that you see here is that in general, the pain doesn't go away. In fact, in the people who have been injured longer, we see that fewer people are without pain, and they seem to be picking it up on the non-neuropathic pain types. Neuropathic pain remains pretty steady in terms of the frequency across years post-injury. And that it's important to note that people who are longer years post-injury are also more likely to be older, so they are more likely to be aging anyway. So that this may account for this, rise or increase in non-neuropathic pain types with longer durations of injury. It could be due to a number of factors, but it's important to recognize that there is sort of this correlation between years post-injury and the age of the participants when we're asking them these questions. So then our main sort of primary aim was to look at the impact of pain by type. So for each of the 3 pains that people could differentiate, we asked them to differentiate. We asked them the intensity of their pain on a 0 to 10 scale, how much pain interfered with day-to-day activities, how much pain interfered with mood, and how much pain interfered with sleep. So these 0 to 10 scale for each of these questions. And then, so what we did was, again, we had 391 participants. 20% of them didn't have any pains at all. So this is the group of participants who contributed information about neuropathic pains and non-neuropathic pains. And remember, a particular person could contribute up to 3 pains. So this is not the number of people with neuropathic pain and the number of people with non-neuropathic pain, but it's the number of pains. So one person could have contributed 3 different neuropathic pains to this, and another person could have contributed none. So this is the overall number of overall neuropathic pains across all the participants and the number of non-neuropathic pains. And what we found was when you do a t-test to compare these measures, that neuropathic pain is more intense, it interferes more with daily activities, it interferes more with mood, and it interferes more with sleep. So this was not necessarily surprising, but one thing that is important to note is that because a person could contribute more than one pain to each of these groups, this is probably not the most appropriate statistical test to do, because some of these are not independent data points. Some of these are contributed by the same person. So then what we did was we looked at the large sample of people, 94 people who had at least one neuropathic pain and at least one nociceptive pain. And we did it within subjects t-test. We did a paired samples t-test. And this way, what you can get at here is that these are related measures. We know that these people, because we're doing it within test, we know that they're using the pain scales and the interference scales in the same way. So one of the things that we have trouble with sometimes when we're trying to compare across groups, when we're looking at pain, is that people can have different pain experiences for sure, but people also can use scales, maybe using the scales differently. What is the most intense pain imaginable to me is not necessarily the same thing that you think of when you think of your most intense pain imaginable. So your 10 is not necessarily the same as my 10. But we know with this group that the person, because it's a within, we know that they're using the scale in the same way. And in fact, what we found was that many of these differences went away with the exception of sleep. So what we find is that on a 0 to 10 rating scale, you get about a 1-point drop. You have a 1-point increase in sleep disturbance or interference with sleep if you have for your neuropathic type of pain. So neuropathic pain interferes more with sleep than non-neuropathic pain within subjects. And although the numbers are larger for neuropathic pain, for all these other categories, they are not significantly so. Okay, so that was our sort of primary aim for this paper, was to see if nociceptive and neuropathic pain types differentially impact people's life with spinal cord injury. The other thing we wanted to look at were factors that were associated with the presence of chronic pain, and particularly these different pain types. So we looked at demographic factors, and what we found was that females, this is true in general of chronic pain, females had more chronic pain overall. There were fewer, only 8% of females that reported not having any pains. So that was a significant difference between females in the non-neuropathic pain types, females were also more likely to report a non-neuropathic pain than their male counterparts. This was not true of neuropathic pain. There were no significant differences there. And then when we looked at race and ethnicity, we didn't see many differences, but we did sort of see this trend that is repeated in both the minority groups, where Blacks or African Americans tend to report having more neuropathic pains. Hispanics also report having more neuropathic pains than, oops, how do I page? And seem to have lower non-neuropathic pain types, report fewer non-neuropathic pain types. And this was significant for the African American group. So when we look at this difference in gender, most previous studies in spinal cord injury have not found differences in the presence of pain by gender. But one thing to note, is that there's only 20% of women represented in the SCI pain population, in the SCI population. So you have to have a large study to have enough female participants to be able to really look at this appropriately. And as we talked about before, it's difficult to differentiate pain types, neuropathic and non-neuropathic pain, when you're doing cross-sectional study, a large study, when you're trying to do sort of survey types of instruments. It's hard. It's difficult to be able to diagnose what type of pain that they have. So even with the larger studies, they haven't looked at many times these differences between the sexes in terms of the different pain types. And we do know, like I said before, this is consistent with studies in other pain populations showing that females in general, for most chronic pains, are overrepresented. And then when we talk about race and ethnicity, this has really kind of not been looked at very much at all in the SCI literature with regard to differentiated pains. We do see that this is true in SCI and in other chronic pain conditions, that minorities tend to report the presence of pain less. So they have a lower rate of having the pain, but they do typically report the severity of the pain as being higher. So we didn't find much differences, although I did, like I said, there is sort of this trend where we're getting some possible differences between minority and majority individuals with regard to differences in reporting neuropathic pains and non-neuropathic types. So another thing that we wanted to see whether or not was associated with pains, neuropathic pains versus non-neuropathic pains, was the level and severity of injury. So because we have the data from these participants from when they were first enrolled in the spinal cord injury model systems, we have what we did was we used their discharge ASIA information, their initial discharge from inpatient rehab ASIA information, to classify them as paraplegic incomplete, paraplegic complete, tetraplegic incomplete, or tetraplegic complete or incomplete. And we looked at differences across the different pain types. One thing that we found is that people with tetraplegia were less likely to have pain in general. So there were more people that reported no pains who were tetraplegic. We also find that tetraplegics are less likely to report neuropathic pain than paraplegics. We did not find differences between the complete and incomplete groups overall. So most previous studies have not reported differences between between the level of injury, so para versus tetra, for example, and the presence of neuropathic pain. Although some studies have, but most previous studies have not reported a difference here based on the level of injury. A few studies, older studies, did initially report some differences between complete and incomplete injuries with regards to being at higher risk for neuropathic pain. So incomplete injuries being at higher risk for neuropathic pain. But most of the more recent studies have not reported this difference with regard to the presence or or the development of pain after spinal cord injury, neuropathic, separate from non-neuropathic, on the basis of complete versus incomplete or severity of injury. So to summarize what we found in the cross-sectional study that I've just described, we overall found that neuropathic pain has a greater impact on sleep than non-neuropathic pain. We found some associations between different demographic and injury characteristics with the report of presence of neuropathic pain and non-neuropathic pain. And this is kind of the thing that I want to focus on a little bit more, just to describe some studies that we are doing right now. So it would be important to further understand these relationships between different injury characteristics or other factors in the environment that can impact the development of pain. So one of the things that intrigues me is that, we have this injury, this traumatic injury to the spinal cord, and only 50% of people after this injury develop neuropathic pain. Given the extent of damage and how this impacts the somatosensory nervous system, it's kind of surprising that only 50% of people develop neuropathic pain, or about a little bit over 50% of people develop neuropathic pain. This is a figure that is showing primarily the impact of a spinal cord injury on nociceptive processing. So at the level of the injury, there are many pain generators or pain generators that you can talk about at the site of the injury. And then also all this, what's happening in the brain is also very important. So the brain has deafferentation, so it's getting less input from areas below the level of injury that it is used to. This is causing changes in the brain restructuring and reorganization, but it's also getting increased input at the site of the injury. So, so the balance of activity in the brain is changing, and there can be hypersensitivity at the injury that impacts sensitivity at the brain well beyond, after some of the inflammation has died down, or even after some of the other neurochemical mediators are stabilized, that has permanently sort of impacted the supraspinal centers that cause this chronic pain to continue on. So let's see. So not to mention, so this is one aspect. This is kind of the sensory aspect that we talk about when we're talking about neuropathic pain or pain in general. This is the sensory kind of aspect. What are the fibers doing? What is the system doing? But what we're missing when we're talking about this, when we're trying to measure chronic pain and see what things affect the development of chronic pain, we're missing all these other things that we know, previous experiences that we know impact pain, and all the affective aspects of pain. So all of these things are also affecting the system. So we can't just measure and worry about the sensory system, what's happening in the sensory system, but we also need to worry about what's happening over here and what these other factors, how these other factors can impact the development of chronic pain. I'm particularly interested in the development of neuropathic pain and how it sort of solidifies it so that it's a very persistent pain, and how it also impacts the severity of pain. So we need to measure these things as well and consider these things. And these things may be part of the reason that only 50% of people who have this traumatic injury develop chronic neuropathic pain. So again, here's our neuropathic pain definition: caused by a lesion or disease of the somatosensory nervous system. We know that that's happening here. One thing that we can do to see a little bit in more detail, besides just talking about complete versus incomplete injuries, is to probe the somatosensory system with some specific measures that we use to see how the somatosensory system is functioning, and look at some of the details in terms of what differentiate who develops neuropathic pain and who doesn't. Are people who have a greater impact on their thermal pain perception pathways, or people who have a greater impact on their tactile, non-painful pathways, due to their injury? Are those people more likely to develop pain, or is it an imbalance? So besides just doing like an ASIA examination and determining sort of this sort of gross differentiation between complete versus incomplete, we can use specialized tools that aren't necessarily appropriate in the clinic because it takes a lot of time to do these, to probe the somatosensory system and see what specifics of this sensory aspect may be related to the development of neuropathic pain. And we have looked at this in cross-sectional studies. So this is again, from my time working with Eva as a postdoc. This was a cross-sectional study in people who had spinal cord injury at least 1 year post-injury. So they were chronic SCI. And these particular data are for people who had neuropathic pain, chronic neuropathic pain, and we measure the intensity, the severity of their neuropathic pain using the neuropathic pain symptom inventory. We could get an idea of the severity of their clinical pain, and it goes from 0 to 100. And what we wanted to do was look at thresholds so we're provoking the system using thermal stimuli presented below the level of injury in the area where they had pain, where they reported neuropathic pain, and we measured their thresholds. And this scale here is a Z-score scale, so 0 here means that you have a normal threshold when compared to an able-bodied individual, a person without spinal cord injury, who has a normally functioning somatosensory system. And one thing that I'll note is that although this cross-sectional study, we did not find significant differences between a non-pain SCI group and a pain SCI group in terms of their thresholds. What we did find was within the SCI group that the worse your clinical pain was, the more normal, or the more close to 0, more close to able-bodied individuals your thresholds were. So you were more sensitive to the thermal pain stimuli, you had a lower threshold, and that was related to having more intense report of chronic neuropathic pain. So we can probe the system and look at these relationships. However, when we do cross-sectional studies, we don't know which came first. Did this residual function, the preservation of residual function in the thermal pathways, did that precede the development of the chronic neuropathic pain and the increase in severity? Or is it the fact that they have, over time, their pain severity, those people with higher pain severity has had a greater impact on their nociceptive system, where it is more sensitive to these evoked types of pain sensations. So it's kind of difficult to figure out which measure impacts the other one more in a cross-sectional study. And that is why we are interested in looking at longitudinal studies. And we're currently conducting one, and we're gonna start conducting a multi-site study soon, looking at this very sort of simplistic schematic of what we're doing. So we're going to be measuring these other factors that we know impacts the development of chronic pain. We're going to look at how they may impact the development of chronic pain in people's spinal cord injury, in particular, how they impact the development of chronic neuropathic pain. We're also going to be probing the somatosensory system to see how much residual activity is left in which parts of the system specifically. And then at the same time, we're going to be assessing differentiated pain symptoms. So we're going to be looking at when do they develop neuropathic pain, or when we first assess them, do they already have neuropathic pain? How bad is it? Or do they have non-neuropathic pain? How bad is it? And we're going to assess it at different time points after injury. So this first assessment will be, or currently we're doing this. The first assessment is immediately post, or not immediately, that's wrong, as soon as possible after discharge from inpatient rehabilitation facility. And then we assess them for all of these measures, and then we follow them about 6 months later, and then again about 12 months after their spinal cord injury. And what we're looking for is sort of which came first, the chicken or the egg. Can we see can we see temporal relationships between chronic neuropathic pain development and severity and these biopsychosocial factors? So all of these psychological factors that may be impacting the development of chronic pain, and their biological or the severity of their injury, and how the somatosensory system is affected. If we can assess, if we can find temporal relationships between these things, then we will be able to better understand the risk factors and the mechanisms underlying the development and the severity of neuropathic pain after spinal cord injury. And this, which is kind of the ultimate goal, is that we'll be able to better treat it or prevent it, which is very important. We may be able, some neuropathic pains, for some people after spinal cord injury, I didn't show this data from the literature, but for some people after spinal cord injury, they have neuropathic pain symptoms almost immediately after their injury. But for a decent proportion of people, particularly for low-level neuropathic pain, their symptoms don't start really popping up as painful until some months later. So it's possible that if we can understand how this develops better, we may be able to prevent some of those pains from developing in the first place, because we do know that it's extremely difficult to treat these pains, neuropathic pains in particular, once they're established. So I don't have any data to present to you with regards to our longitudinal studies. We're currently conducting a site-specific study where we are here within our site, looking at many different aspects of the sensory system and how that might be related to development of neuropathic pain. We have received funding from the DoD to do this multi-site study, looking at a sort of bedside examination, probing the somatosensory system to see if we can do assessments even earlier after injury and see if across a larger sample we'll be able to find any relationships longitudinally. So with that, I want to thank everybody that is involved in the spinal cord injury model system. You'll notice Dr. Nash was not available the day that we took our picture, so I've inserted him there. Thanks to everyone who has collaborated here at the University of Miami, and also writers at our other sites within the model systems.